All right, good afternoon or good morning, depending on where you're joining us from today. Please note that this meeting is being recorded. If you do not consent to being recorded, you are asked to drop off the meeting at this time. Thank you. And I'll wait just a few seconds in case anyone does want to drop off. All right, well, my name is Darby Gallagher, and I'm a member of the Miami Tribe of Oklahoma, as well as a project coordinator here at the National Indian Health Board. It is my pleasure to welcome you all to the first part of the final webinar in the NIHB Association of American Indian Physicians Active Love COVID-19 Vaccine Webinar Series. Today's webinar will focus on tribal involvement in the Novavax COVID-19 vaccine trials. And part two, which will be happening later, will focus more on the development of the vaccine and will feature some speakers from Novavax. All right, so vaccination is the strongest tool we have to fight the COVID-19 pandemic, and there are several COVID-19 vaccines available, as well as those in development. Vaccines play a crucial role in protecting tribal elders, youth, tribal communities, and yourselves. So it's important to understand all options available. During today's webinar, we'll be hearing from members of the Lummi Nation who will be telling us about their experience working with Novavax during their COVID-19 vaccine clinical trials. We do have one speaker who is a little late, but that is a-okay, they are busy. But we do have one of our councilmen here with us today, Councilman Nick Lewis. So I don't know, Councilman Lewis, would you like to introduce yourself? Tell us a little bit about you.
Yes, good morning or afternoon, everyone, wherever you are. My name is Nicholas Lewis. I serve as the secretary for my tribe, the Lummi Nation in Washington State. I'm the chairman of the Northwest Portland Area Indian Health Board, which represents 43 tribes in Washington, Oregon, and Idaho on health policy work, and am the vice chairman on the National Indian Health Board. And just thankful to be here with each and every one as we talk about what we're doing to protect our community and be able to share a little bit about specifically what Lummi Nation has done, or the path we took, especially with Novavax. And I know our doctor is has another conflicting meeting, but he will be with us shortly, as we heard Darby say. And I think when he gets on, he'll be able to share some really good in-depth information about the direction and why we had to do what we did and participated in the trials. And look forward to the Q&A and back and forth and helping however we can. Thank you, Darby.
Yeah, thank you, Councilman Lewis. So let me see, sorry. As I mentioned earlier, this is the first part of what's going to be a two-part webinar series. And again, this first part is going to be focused more on tribal involvement, and the second part will be focused more on development. Let me see here. Councilman Lewis, how do you feel about starting Q&As?
What was that?
How do you feel about answering some questions?
Well, I'm all for it. I am a council member, and some of us know how council can respond, but I will do my best. But I think these type of conversations are things that we need to do more of, and so survive some firing lines and welcome any questions. We're all better for the conversation.
Perfect. So I actually have a few pre-prepared questions. And then once I get through those, if anyone watching has any questions, do please feel free to ask them. We do have the Q&A box, we have the chat box, or if you feel comfortable doing so, you can use the raise hand feature, and an NIHB staff can unmute you. And we can go ahead and get started with our first question. So, Councilman Lewis, why did you decide to participate in the clinical trial? Was there anything specifically guiding you towards doing this rather than getting like the Pfizer or Moderna vaccine?
Thank you for the question. For me personally, one thing my grandparents had told me growing up, my grandparents raised me, and they had said, wherever you go in life, whether as yourself or as a parent or being on the council as one of the elected leaders for our people, don't you ever ask your people to do something if you aren't willing to do it yourself. And when you look at how COVID impacted each and every one of us, one of the things that, while I don't know your answer, I would believe in, is that there was a lot of fear, a lot of worry, a lot of the unknowns when this started a few years ago. And what we did know is what we seen on the news. We seen videos and the stress and just the worst of COVID, especially when it was big in Italy and Europe, and or kind of in China. And our doctors had told us when this started, or when they started to see this, that can be us at some point in this pandemic, and we need to do everything possible or within our power to prevent it. And when our medical or public health team had brought wanting to participate in a trial, Novavax was not our first one that we were working with. We worked with AstraZeneca as well, and we had personally learned a lot. The trauma of healthcare in Indian country is real. Our people were harmed at the federal government's hands. And so when we talked about opening a trial with a unknown drug or unknown vaccine, there was still a lot of fear in that. And I'm glad I seen Dr. Lane on, and he'll be able to get to his presentation, but and I'm sure he'll probably be able to say the same thing, is it brought a lot of trauma back to our community. And we actually, with talking with our community, pulled out of those AstraZeneca ones. And then when the opportunity for Novavax came in, because we had taken the time to listen to our community's concerns, we were in a better position to try again with another vaccine trial. And for me, especially as a health rep, I will always support our public health recommendations, even if it's a personal challenge at times. That's what we're here to do. Our job is to keep our people safe. And as I mentioned, my grandparents told me, don't ask anybody to do something you wouldn't be willing to do. And when our health team came with us, or to this, and even the council, we had council members that were uneasy about it. And I said, well, I'm going to support our health team's recommendation, and I would be happy to be one of the first ones that does the Novavax. I think because of being on council, they did have cameras there, so I actually was the second one. I got beat by our health commission chair, but it boils down to taking care of your people, doing everything you can, and trying to lead by example. And so that's why I did. But I do see Dr. Lane is on, and I don't know if he has a good presentation or wants to respond to that as well. But it was personal for him as well, I know. Dr. Lane.
Thank you so much for answering, Councilman Lewis, and welcome, Dr. Lane. It's so nice to see you. So I did just ask Councilman Lewis a question. I'm not sure if you would like to try answering it first, or if you want to go into the presentation first. I'll let you choose.
What was the question? Maybe it'll be answered in the presentation.
Yeah, so the question was, why did you decide to participate in the clinical trials?
Oh, yes, that'll be answered in the presentation.
Perfect, yeah. So if you want to just introduce yourself, then we can get started. with the presentation?
Sure. My name is Dakota Lane. I'm the medical director here at Lummi Tribal Health Clinic. I'm also an enrolled Lummi Tribal member and have been in the unfortunate position of having to help manage the health system of Lummi during the pandemic. It has been an experience that you can't really prepare for, and you really lean heavily on council leadership, on the community elders, and then also just generally the team to get through, the healthcare team to get through this. And so the big question is why did we decide to do Novavax? And I'd like to start with a presentation. It's going to be a little bit roundabout, but I think it's important to understand the context in which the Novavax was introduced into our community, because that helps describe it. So without further ado, let me just get this going. I put this together, so I hope you guys don't mind. I think Nick has seen versions of this. And so this is just a presentation on kind of our COVID response. This is a picture. This is a Dr. Toledo. She is our former public health director and now works for Harvard. And this is our first, she's responding to our first positive COVID case way back in March 12th, 2020. And then this is probably one of the first of our PCR testing in February. And this was our dentist, Dr. Giltner, because in the very beginning, we shut down dentistry because of the high risk of aerosol transmission. So the dentist offered to just do our testing. And I think that's a function of how flexible you need to be in the pandemic. So, okay, so public health in Indian country, I just wanted to point out that we were affected like many of us in the very beginning. That is a picture of me. I was exposed to our first COVID case, and I had to be quarantined, and Seattle Times did a nice article on this. It made it sound like I actually got COVID, but I didn't. I just had to be quarantined. But the main purpose is that prior to this, we had an extensive preparation, of which Nick Lewis was involved with council. We had an emergency plan in place. We established some strong community partnerships. And then also we built some surveillance testing, quarantine down here at under the gray here. And then we had to quarantine homes. And then also when you quarantine people, you have to provide support like food delivery and other issues that come up like internet, electricity, water. All those things are needed by quarantine homes or people in quarantine so that they can stay quarantined. This graph probably represents the best understanding of why it's great to do public health in Indian country. What you see here is a logarithmic graph. You see, and it talks about the number of cases. You see this steep line, this least steep line, the blue line here is the doubling of cases every 2 weeks. This yellow line here is the doubling of cases every every 7 days. The gray line is every 5 days, and the orange line is every 4 days. But then, of course, we have our line, which is the actual number of cases. And so what you see is the very beginning of our COVID response. Day one was patient 0, whereas our patient 1, for that matter, is March 12th, our first case. And immediately right after, we shut down the schools the next day. This required extensive policy response. Shortly thereafter, I know Nick has some stories about all of the ongoing discussions about closing the casino. That's like sacrilegious. We would never, what tribe closes their casino, right? But they did it.
I think at Dr. Lane's request, just for everyone here, I was called crazy and other words, but that was the fear, the worry that I think we all had, and people not realizing how it will impact so much. And It was a tough conversation. It was not easy. There's a lot of people angry with myself and Dr. Lane and others for pushing a radical public health lens topic, but never thought I'd make a motion to close our casino down and our revenue source, but we did it. And it was about saving lives and saving our people. And I'm glad Dr. Lane's going to go into some more topics, but we're better because of Dr. Lane and our whole public health team. They saved lives that we don't even realize.
Yeah. So, and you can still see that despite all these, our cases are still rising. Shortly thereafter, we did something called shelter in place. I think many in Indian country are familiar with this. And you can see that, so this is March 22nd, 7 days later, which is about, or 5 days later, maybe, well, 7 to 8 days later, we finally flattened the curve. I don't know if you remember, 2 years ago, that was all the rage. Let's flatten the curve, let's save our community. Well, Lummi was able to do it, and not just once, but also twice. We had our second outbreak a month later, and then we shut it down even faster. And then, of course, we had a third outbreak in July. But one way to look at this is that we had to implement these policies, and with each outbreak, we could easily flatten the curve. Of course, we go into September of 2020, and then we go into the winter. It gets kind of more crazy. So that is real-time public health policy in place. They do require extensive policies. Like, we had to implement all of these different policies. These are just a few to name. Here's the shelter in place. This policy right here gives the, I can't believe council did this, but they did, gave the executive medical director the authority to have someone arrested who doesn't follow public health policy. I actually never have had to use this, but we have probably threatened to use it maybe 10 times, and then people listen. I recognize this is a power that I just really hesitate on, but nonetheless, that was in place. Of course, we had the routine travel policies. These are all the things that had to come out. So what it just kind of fast forward to October of last year, we had a total of 660 cases, 20 hospitalizations, and 5 deaths in October. You can see that it spread pretty broadly among the different age groups, with the highest risk at that time, 0 to 50. All of our elders naturally led the way. They didn't have any cases or as many cases. They were also the most vaccinated. And I'll get to vaccines in a second. So I'm getting to your answer, Darby, but I wanted people to understand the context in which we were dealing with vaccines. This is another way to look at the number of cases we had. This is from the beginning of the pandemic to October of last year. You can see December, January of 2020 to 2021, a year and a half ago. That's what this was. Here is our public health team, and I'll get to the vaccines in a second, but we have Dr. Toledo here. She has since moved on, and we have a new public health director. We have a quarantine coordinator, which is Sarah Cook. We have our data analyst, Derek, 2 nurses, Alyssa Lane, who is also a Lummi Travel member, and then Rachel. And then we had a CDC fellow, Zubaida. And then we had our contact tracer, Mandy, who is also, she's actually tribal from Skagit. She's married to a Lummi. They did a fantastic job. So up to October, they had distributed over 11,000 vaccines, and that includes non-tribal. We've did over almost 7,800 COVID tests. And we had, at the time, 9 quarantine homes available. We also, like I talked about delivering food to quarantine homes, we delivered over 3,700 meals to those homes. That's an insane amount. Can you imagine delivering 38,000 meals? I didn't even think that was possible, but somehow, this team did it. So real quick, vaccines. as of October, this was the numbers we had. It's certainly gone up. I think we're now like 74% fully vaccinated. We also, sorry, this is vaccination. Yeah, so vaccinated tribal members. So this is, then you fast forward to January, and this is our numbers. You can see we're at 74% vaccinated. The biggest, and I think this is a national thing, the biggest thing is we actually aren't doing a great job vaccinating our children. Ages 5 to 11, 70% are not vaccinated, and only 8% have received 1 dose. And anecdotally, that's what we're seeing in our cases. It's carried by our kids and then goes home and then infects the entire home, even if you're vaccinated or boosted. And this one is, our data is incomplete. This is from Omicron. We're trying to analyze this data. It's really raw data. 12 and older is not vaccinated. I think there's some mistakes in here, but nonetheless, this data, and we just got to learn to work on it. Okay, vaccines. Quickly get into 1 second, Isis. You have to wait, please. Wait here. I'm watching my daughter this time. She, her daycare has sent her class home from exposure. I'm sure it's a common experience. Very frustrating and disruptive, but that's the world we live in. So back to the vaccine strategy. Lummi has explored all of these vaccines and have offered, except for AstraZeneca. Obviously, the Pfizer is the most common one. Moderna is also one. Johnson & Johnson we used to offer, now we no longer do because of ineffectiveness. Then, of course, AstraZeneca and Novavax. We knew that in the very beginning, all of those policies we needed to put in place so that we could basically buy time for vaccines to be produced. Think about it. 2 years ago, it was even like a year ago when the vaccines were just starting to get implemented. And even still, they were limited. You had to be like elders first, who are first responders. And so we really had to do it. So bringing vaccines to Lummi, we started the discussion April of 2020. So 2 months after our first, almost 1 month after our first case. Then in August, September of 2020, we submitted a IRB application for AstraZeneca. AstraZeneca does make a vaccine. It was widely used in Canada and the UK. Actually, the majority of vaccines in the UK were AstraZeneca. We approved it to move forward. The commission, we have a health commission, then council approved it, approved AstraZeneca to be offered in our community. However, from the time of council approval to for about a week and a half, there's a lot of things that happened. The first was some new studies came out, heavily publicized, of transverse myelitis. Transverse myelitis is a muscle disease that causes weakness. Sorry, not a muscle disease. It's a neurodegenerative disease that causes weakness and numbness. And so the vaccine trial was paused days after LIBC approved the vaccine trial. And I can tell you, the community was not happy. It was really, and so, the idea, and then on top of that, if you can rewind your head, September of 2020, President Trump was heavily pushing for all these vaccines to be released by elections. And there was a strong concern locally by our community that we would release vaccines without full safety review. September of 2020, Pfizer wasn't even out. Moderna wasn't even out. That's how long ago, and this is, it seems like a lifetime ago when we were dealing with that, but really it was only almost a year and a half ago. Wasn't that long ago. Community response was, not surprisingly, largely distrustful. Facebook, a huge medium for backlash against tribal leadership, and I include myself in that, comments like, how much did they pay council for this? I don't want to be guinea pigs. And then more closely to my home is my own, remember, I'm a Lummi tribal member. I have 12 aunt and uncles, countless cousins, and certainly they would ask me, my aunts and uncles, nephew, why are you doing this to us? So it was a tough time. So naturally, after all of the feedback we got from the community, we withdrew from the AstraZeneca trial. And I actually don't
Dr. Lane, I think you
we
might
decided.
be, oh,
Yeah.
I think you froze for a little bit, at least on my
Oh.
end. Yeah.
Oh, I think that was my end. Sorry. Was it like this? That froze?
Just about 30 seconds. You paused with a smile, so it was good.
Oh, good. I wasn't picking my nose. Okay. I forget where I froze, but I didn't. So I don't see this as a failure. I see this as the processes that council and a public health team put in place worked. It allowed for good feedback from the community, allowed for good input from appropriate tribal leadership. And then it was the community and council making the decision, you know what, we don't want to do this. And then we rescinded our ability to do this. And so then we switched to Novavax. And thank goodness we did this. I think Novavax is a great vaccine. I didn't know it at the time, but it worked out to be just that. This is a picture of our mobile setup that we did. You can see this is actually Dr. Scott McClellan on the left. He is the principal investigator from UW that we work closely with. And then of course the respective team here, Dr. Cholito on the far right here. And way back there where this is our -80 freezer that became important later when we needed to get Pfizer vaccines. We were one of 2 sites in Whatcom County that had this. The other was the hospital. And then also we were the only tribe along the I-5 corridor that had a -80-degree freezer. And we got this for starting preparations for AstraZeneca. So all of these infrastructure things that we put in place, despite it not being as successful as we had liked, opened up new opportunities for us in the future. So to Novavax, we went through the same process. November 3rd, we got it approved by council. And I had to include this, Nick. I'm embarrassing you. Vice News came and did a nice thing on us. There's Nick. I'm about ready to go swab him just before getting the injection.
I don't know if you could see, but I'm like, are you? that I trust our doctor and yeah.
Yeah. So if you, I didn't include the link here, but if you just put in Vice News and Lummi, this is one of the ones that pops up. It's a nice 5-minute piece. And it turned out to be a huge success. 93 efficacious against variants of concerns and interest. That does not include Omicron or Delta. It was mostly the British variant and Alpha and the original variant. So unfortunately, those viruses did not exist by the time the study came in. That's not to say we didn't capture that data. When Omicron came, we did get good data on those, and I'm eagerly awaiting publication of it. But nonetheless, 91% efficacious in high-risk populations. All COVID-19 hospitalizations and deaths occurred in the placebo group. And as a matter of I guess, pride, I also ended up being a co-author on this article here. You can see my name here. Oops, see my name here. I never intended this. I'm just a family med doc from a small tribe, and somehow I ended up on this. So it's a testament to the amount of work that Lummi put into this. Vaccine strategy, here's the fridge I talked about. Here's our team. That's the first box of Pfizer vaccines we got. December 17th, we offered the Pfizer vaccines. That's Jim Scott, the first elder who received it. So we had to develop our own vaccine distribution. We got so many vaccines. Lummi also, along with many other tribes, I should note, along the I-5 corridor, offered vaccines to a lot of non-tribal groups. including ones that took care of our tribal members. And so we helped distribute, vaccines to non-tribal people. We gave it to bus drivers. We gave it to, we have a ferry here that goes to Lummi Island. We gave it to the ferry people there. Anywhere we offered it to the local grocery store. Anywhere Lummies went, we wanted to give vaccines, and that's what we did. So just some idea. This is just to highlight, certainly everybody on this call is aware of this, but natives still continue to have higher risk of hospitalizations. On the left here in the bar graph, and then even on the right, we still have increased cases, COVID cases within tribal populations. We have a unique risk. Here's some more data on this, and I'm just going to quickly go through it. Vaccine equity, just as a highlight, we wanted to make sure that we were worried that tribes, in particular Lummi, would be the last in line to get the vaccines. And so part of doing the vaccine strategy was to, oh, Nick, were you raising your hand there? Sorry, I didn't. Okay.
No, you're good.
Okay, was to make sure that we continue to have access. But nationally, you can see that tribes still struggle with getting the vaccines in place. Here's some more data on that. I'm sorry, I had to, and that's it. I hope I think we have 20 minutes left, but I wanted to, so long story short, here's the answer. Why did we do Novavax? We did Novavax because we wanted to make sure that Lummis had every opportunity, just like white people do, with access to experimental drugs. One of the biggest complaints is, a lot of these drugs that are experimental, they start off by being offered in academic centers. And the majority of people who have access to those are white people. In fact, it was a big, way back when Moderna, when they first did it, was like 98% white in their trial. And Novavax and NIH pushed for it to expand to include high-risk populations. And that's where we, Lummi, fortunately benefited from that change in policy. And there were some other tribes. I think White Mountain Apache also participated in this. So did, I'm drawing a blank, but a tribe in North Dakota. I think I'm one of the Dakotas. And so, and Novavax had the highest participation of indigenous people than any other trial ever. 6% of indigenous people participate. I say indigenous because they also include Mexican indigenous, because there's Mexico and the United States. And so that was roughly 1,800 indigenous or American Indians or Alaska Natives participated. At Lummi, 64 actually enrolled. It wasn't that many. But nonetheless, it demonstrated, it actually, because of that, it started the discussion on vaccines. We started discussion of vaccines way back in September. And it really engaged the community. And in many ways, the vaccine trial forced the community to ask tough questions, to challenge council leadership about these vaccines, to challenge myself and my healthcare team why vaccines were important. So we started this discussion a long time ago. And, I think it worked. I think it's great. Obviously, lots of areas for improvement, but it was well worth the endeavor. Yeah, so with that, I hope that answers your question, Darby.
It did. That was such a great presentation. Thank you so much. Don't be surprised if you see an email from me asking to pick your brain later.
Sure.
Yeah, that was really great. You did answer actually a bunch of my questions that I had prepared. But I will go ahead and ask both you and Councilman Lewis this one. You guys might have different answers. I'd like to hear what you guys both think. And you did kind of hit on it, but what was the experience like working with Novavax and being involved in a clinical trial? Did you learn any lessons or have any advice for other tribes who might want to do the same thing?
I can add a little bit more. I know Dr. Lane might have some good in-depth part, but from the journey of AstraZeneca getting to Novavax and just having to vet a lot of the tough conversations, it was able to help us with easier conversations with Novavax. One of the things that I mentioned earlier, when we talk about experimental drugs that aren't fully approved, we have to acknowledge the history of the wrongdoings, so that they used medical as a way to cause harm to our people. And that was, we were reminded of that when we heard from our people. And even in other medical applications today, there's still harm that can be caused. And one of the things that helped us, and I didn't know if I missed you mentioning that, Dr. Lane, or if you mentioned that with Novavax, we did work with them on an agreement that we own our data and have the right to own it, so that it can't be used without our consent. Because that was another thing that our people spoke on, is medical research can cause harm when it's talked about. And so it was really important that we're able to do that with Novavax. And from the staff that came up here to Lummi, to those at UW and with the tribes, I thought everything was done well. They did a lot of preparation. They were very calculated in how to do things, and it made it easier for everyone, and we're better for that. I would say with Novavax and the others, I think that we were one of the only ones in our area, if not the state, that for tribe at least, that was offering 4 vaccines at any given time. We did everything possible. And I remember telling our chairman at the beginning with COVID that we will not see a success as we define other things as success. To us, success we will not see the data that we might see otherwise. We're going to see lower data in regards to death and all those other things. And what I can say to where we are today, that we have been overly impacted by COVID at higher rates. And the data supported that nationally. But because of our public health doing all that they did, and Novavax is a big part of that, that we have lower data when it comes to death and the seriousness that it's caused. And so that's a testament to, that's why we follow science. That's why we follow our healthcare. And Novavax was professional and respectful in every conversation that I've been a part of. So turn it over to you, Dr. Lane.
Yes, so I think, so Novavax itself and kind of vaccines in general, there's a lot of things that went into play leading up to it. The first is an understanding that each tribe needs to have the infrastructure in place. I didn't really highlight this too much, but I think the most consequential decision the tribe made was actually made in 2018. And that's when they decided and gave me permission to hire Dr. Toledo to help build a public health department. And the original goal was not the pandemic. It was mostly just to build a public health infrastructure. That was 2 years before the pandemic, and Dr. Toledo started doing it and then just kicked into high gear during that point. So we have a really good, robust public health team. The other thing is to implement research, so to say, also requires access to an IRB that understands the needs of a tribal community. And that's what Nick Lewis, Councilman Nick Lewis was just highlighting. We have, for those of you who don't know, well, the National Indian Health Board, I'm sure many of you know about internal review boards, but IRBs are a great, they're usually in academic centers, tertiary academic centers, that review all data related to all research related to tribes. Now, tribal IRBs are different. Actually, all academic research IRBs only focus on patient safety, which is a good thing. But what they never focus on or take into account is actually community, what we call community harms. And that's what Nick was referring to, and particularly around stigmatizations. I'm fairly certain that every single tribe has an experience where a university researcher comes in, does research, then runs away, publishes it, and it's not even close to what the tribe or the tribal community wanted. And all it ended up doing was advancing that researcher's career. With the harms and the risks really being absorbed by the community. The biggest one that I think many of us probably can think of is the so-called Navajo flu that occurred in the 90s. There was some respiratory sickness that was going around. It turned out to be the hantavirus, but nonetheless, some publication went out where it said the Navajos afflicted by flu-like illness, and media took it and said Navajos have Navajo flu, and it wasn't anywhere near. It just wasn't what the tribe wanted, my understanding, and they didn't like that language. So this IRB really, the IRBs really need to be aware of what the harms are done. So we have a really good health team. We have a really good internal review board, institutional review board, sorry. And then we also have the political oversight. So we have our health commission, which is used unpaid, is boarded by all of our community members who got a say in it. And then then finally it'll go to council. And things like this should go to council. They should say yes or no if you want an experimental drug to be used on your community, which is kind of weird to say. But what I would suggest to those on this call is that you really we were able to do what we did because a lot of the infrastructure was in place. Wasn't perfect, and the pandemic really accelerated the development of it, but it was in place with the right people at that time. And so, long story short, to your Novavax question is, did we enjoy it? It was just more work, and it was the right thing to do because at the time, there was no guarantee Pfizer was going to be that great when we started this conversation. There was no guarantee that the vaccines were going to be as successful. And so remember, in order for a vaccine to be successful when they designed these, was it had to be better than 50%. So at least half of the people benefited. That was all the criteria. And thanks to modern science, pretty soon it was normal for it to be 90% or better. And so then that was the expectations. And so that really is a miracle of historic proportions with that when the vaccines came out. And it for a lot of, surprisingly is still quite effective, even against the evolved variants. So I think when tribes look at this, as building the infrastructure to succeed and protect your community. It's a multi-year process, and it starts with it starts with the council and political leadership saying this is where we need to go. What we did today could not have been done without political leadership that saw the value in it. All you have to do is just look at how, despite what people say about Trump, he did sign off on this vaccine. He approved the development of this vaccine. And despite his rhetoric, that put question into the vaccines. So it took political leadership to invest in this type of experimental vaccines. So the point I'm trying to make is that it does require, if you're a healthcare provider or in the healthcare industry, it does require you to advocate political leadership to take us this direction. Sorry, I kind of talked for a while, but.
That's okay. You answered a bunch of questions that I was going to ask anyway. I think we have time for one or two more. And I think this one might be more for you, Dr. Lane. Were you tracking outcomes data internally with your own systems, or did you rely on partnerships with state or other partners during the trial?
For the trial only, I was relying, like actually doing experimental trials. I actually don't have access to the data. Only Novavax did. And then a few other, what we call the Data Safety and Monitoring Board that was established nationally. They're the only ones that have access to it. So with regard to the trial data itself, it was only managed and monitored by Novavax and probably a few other people at NIH. And so that does not mean I didn't get to see the published results. So part of our data safety and monitoring agreement between the tribe and Novavax was that I would review any publications to make sure that it's not, no community harms were being done. And that was a whole nother, I mean, I'd never, would sit with the senior VP of Novavax, the legal attorney for NIH, for Fred Hutch, for UW, and for Novavax, and then have to defend myself and advocate for the rights to tribes to their data and negotiate. That was an experience I'll never forget. And I think at the end of the day, I think all of them really saw the value in it. And I would like to believe by advocating for this level of protection, it forced them to think about what types of data they're going to publish in ways that they probably wouldn't have. And it's for the better.
Yeah. Okay, so I think this is our last question. I know we've kind of touched on it, but Councilman Lewis and Dr. Lane, would you encourage other tribes or tribal citizens to do the same thing and get involved in future clinical trials? Yes, no, why, or why not?
For me, what I would encourage is for leadership to look at the reality and the importance of what public health can do to protect your community. We're in a time where a lot of people became health experts, whether it was watching Fox News or CNN or whatever other news outlet or listening to the local healthcare providers. These last few years, we all had to learn to some level. Yes, there's a lot of misinformation out there. And while I know with experimental drugs like this, I would encourage anyone to go through the tough conversations to protect your people. These shouldn't be things that we are scared away from when it comes to potentially something that can save people's life. When we look at the reality of what it did to countries and places that were hit hard, it broke health systems. And without our health, we have nothing. And so I would challenge anyone to go through the conversations, whether it's with this or anything else related to health. People need to take these conversations more serious. And I'm glad and thankful that we did. You know, it wasn't easy. I still tease the other council that called me crazy on the record, and all these other people and can say, you know what, even they'd say we did the right thing. And it's by having the conversations with leadership and the health providers and the community, you'll get to a process that we can all stand behind. And I think that's what we've done, is we've all got on the same page. We did the storming and the norming and all the other things that they say with that kind of model. But that's what I would say. And it is each tribe's and each community's right to choose what's best for them. Some maybe, some not, but go through the conversations to protect your people. That's it for me. Dr. Lane?
Yeah, you know, certainly the perspective of Nick as a council member and also as a patient is like, that's a great view. From my side, so I went to med school. Well, I went to medical school to become a doctor and serve my community. And as Nick said, sometimes the right decision is the hardest decision you have to do. This was one of them. I very well knew the history of vaccines and hesitancy of any kind of Western intervention. I think every tribe feels that way, but it doesn't mean, by limiting yourself to those historical arguments doesn't allow you to expand access in a way that's safe for the community. It requires, I described a pretty significant infrastructure that was built here, even that was started before. If you don't have that, there's nothing wrong with partnering in other tribes. I know like locally, this is a national panel, right? Or is it mostly? Yes. Okay. So locally, we have the like the Northwest Portland Area Indian Health Board. There's all these local lobbying organizations that may have some level of capacity, and it's just understanding what resources each tribe has. So the short answer to your question, if was this a good thing or the right thing to do? The answer is yes. If for the very reason it continues to provide high-level access of tribal community members that do not have access to the latest and greatest medications. And so vaccines were unique for sure. It's not like I wouldn't like take a cancer drug and do it here at Lummi. I wouldn't do that. Obviously, you want to be thoughtful on which investigative, they call it IP, investigative product that you would put into your community, and it needs to be the right one. The pandemic produced risks like nothing we've ever seen since World War II, I'd want to argue, whereas a complete threat to all communities. And so with such high risk, you have to be willing to do the risk to take some risk for the improvement of your community. And this was just one model. For all the tribes on here, I encourage you to look at your local resources, and if it fits, then go ahead and do it. I know we weren't the only tribe. I should also be clear, Nooksack was part of it. So it was Lummi and Nooksack. Nooksack also sent some of their community members. Nooksack is about, 30 minutes, 40 minutes from us. And so Nooksack also, their council leadership also took risk and decided to participate in this as well. And I think they benefited from it as well. Thank you.
Yeah. Someone did just ask if a recording of the presentation will be made available. And yes, it will. It will be posted on YouTube shortly, sometime this week. But I do want to say thank you both for joining today. It was super insightful. I am so glad I got to learn more about it. I was so excited when I was like, oh yeah, we get to talk about clinical trials today. But again, yes, thank you both so much for joining us, and thank you everyone in the audience for joining. Please stay tuned for more information that will be coming up on part 2. If you have any additional comments, concerns, questions, anything at all, please feel free to contact me. I'm posting my email in the chat box right now. If you have any questions, comments, concerns, shoot me an email. And with that, I will say thank you all for your time, and please be safe.
Thank you. One quick thing. Should I just email this presentation to you, Darby, if you want to distribute? Okay.